Over to you, sir.
Thank you. Good afternoon, doctors. Welcome to this webinar on the role of oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare. Hetero Healthcare, as you know, is an innovative pharmaceutical company. Our journey began in 1993. We have 30 plus years of excellence and 36 state-of-art manufacturing facilities. With 300 plus products in portfolio and presence in 126 plus countries, Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world, and has Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of oseltamivir in flu management. We have got moderator Dr. Sridhar, welcome sir, and speaker Dr. Sri Krishna Surampanti, welcome sir. Dr. Sridhar is practicing since 20 years as Professor, Apollo Hospital and Medical Science and Research, Director, Neo BBC Hospital, Hyderabad, Treasurer Secretary, Twin Cities Branch 2122, 2024, Joint National Coordinator, CIAP 24, 25 Presidential Action Plans, Secretary, PATS 2025-26, Medical Legal Expert, and has major achievements as 979 national and 1 international publication, Additional Chief Organizer Secretary, Pedicon 2025, Organizer Secretary, APPA Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, Vidya Ratna Award 2023 from Dr. B.C. Roy, Mother Farm. Welcome once again, welcome Dr. Sridhar. Dr. Sri Krishna Surampudi, sir is MD DNB, consultant pediatrician, professor and head of the department pediatrics, Apollo Institute of Medical Science, Hyderabad. Welcome, Dr. Sri Krishna. And this is this brief introduction. I hand over the session to Dr. Sridhar. Over to you, sir. I'll stop sharing.
Thank you. Thank you. One second. So, able to see, sir?
Yes, sir.
Sir, Sri Krishna garu,
Yeah,
to see?
we can see. Sir, you can put in the slide share.
Yeah, I will.
Thank you, sir.
Yeah, able to see, sir?
Yeah, very clearly.
So, first of all, I want to thank Heteropharma for giving us this opportunity where the need of our of Oseltamivir has to be when to be taken, what are the conditions, and how is the treatment protocol, and what are the side effects? Is there definitely any side effects are there? What is the mechanism of action? These are all should be known to the doctors who are prescribing this Oseltamivir drug, and it's a beautiful drug. Before that, we let us start the these are the basic contents: healthcare challenges in monsoon and their diagnosis, influenza, its complications, clinical evidences of oseltamivir, and guideline recommendations of for empiric use of oseltamivir. On these heads, we are going to discuss in this 1 hour. And you know very well, influenza. What we know about influenza in India? We get normally the fever will be there, body pains will be there, and we'll be get confused with the other viral infections and other bacterial infections. So what are the main things we should know about the influenza in India? When it will happen? What is the spike? When, which months the patients will be more affected with influenza, and which season, and correct time to vaccinate? Because as a pediatrician we should know about when to vaccinate the child. So 5 to 10% of all acute respiratory emergencies are due to the influenza, and 10 out of 100 child years suffers from influenza. And there are studies which has shown between below 1 to 2 years, 180 to 178 of 1,000 children are affected with this. And influenza associated acute respiratory infections are around 33 to 44% of 1,000 children per year. And you know very well, very much 2009 pandemic was there, which are 22.8% are positive for influenza. And in 2019, up to March, there are 30,000 plus cases are positive, but 1809 died because of the influenza complications. So 1809 is a very big number coming to the children part. It's a very big number. So in order to avoid this mortality, so definitely there are some evolutions in the treatment protocols, evolutions in the this treatment management. So this will be dealt today. And you know very well, whenever the month-wise trend, this is taken from our vaccination book, which had shown January to April there is a peak of influenza infections, and also from July to October. So the best time to seeing this scenario, the best time to vaccinate is in either November, December, and also in May, June. If you vaccinate the child in these months, these two peaks where we are seeing in January to March and July to October, these can be avoided if the children will not be getting the infection. And from the same book, Global Burden of Disease 2017, the total hospitalizations are 5 lakhs 88,000, deaths are 26,000, and this is a huge number causing due to influenza having lower respiratory tract infections and complications. Both the mortality, morbidity, and hospitalizations are very huge when the infections are there. And year wise, I will not go in depth. The latest is 2022. Number of cases traced 12,881 and number of deaths are 399. So the pattern of circulating strain in India varies zone wise. Central India, North India, South India, and winter. And winter and monsoon, you know very well, as earlier said, peak occurs. South India, that means ourselves and also Kerala, Tamil Nadu, Karnataka, these people will be having, children will be affected in September to November, and North, January to March. And there is a beautiful study in like 7 years cumulative study in Tamil Nadu where influenza positivity started with the onset of monsoon, peaks during the post monsoon months also. So each zone will be having very much different studies and different peaks when to take the vaccine and also when the child will be more affected. And the most important thing is healthcare related challenges in monsoon are influenza like illness and what we are discussing today, H1N1, and severe acute respiratory illness, SARI, and also COVID-19 is the differential diagnosis for this. And overview of this pie diagram is what we can say is a bar diagram. In 2019, you can see the cases of influenza infections are 28,798, whereas deaths are 1280. So this is only bar diagram I want to show. And I request Sri Krishna Garu, till now the brief introduction I have given. So I request Sri Krishna Garu to tell about the types of influenza virus and what is the mechanism of action. Please, sir.
Thank you, Dr. Sridhar. As everyone knows, these types of influenza virus are A, B, C, which we used to read since beginning. And in that, there are differences are there. Type A influenza is known to cause a frequent epidemics, and this is the one which always give tension to the community, that sudden occurrence, and sometimes huge pandemics also can occur with this. Whereas the type B is usually restricted to few areas and it causes local epidemics. Whereas the type C is infects basically humans and swine. That's what the swine flu once we well known it was. And it generally it cause only mild respiratory illness, and rarely it can be very serious. So at present, what we have seen even in our hospital also, circulating influenza are subtypes of A, that is H1N1 and H3N2. Next. So we know how this transmission occurs, because like any other respiratory viral infections, the transmission of the flu virus also occurs through air droplet, especially when the person cough or sneeze or talk. And because they can land in the mouth and nose of the people, and slowly it gets inhaled into the lungs. So usually it's so rampant that just like a COVID, those who are staying in one house can become, everyone can be affected. And the second method of transmission of flu virus is uh, frequent hand shaking and other things. As we know that good hand wash is one important preventive measure for the avoiding the spread of flu virus. So we should be frequently wash hands with soap and water. Here, the most healthy infants may be able to infect other people from day 1 onwards, and to day 6 or day 7. And whereas children sometimes, because they are immunocompromised in general, they carry the virus for prolonged period and may transmit the virus for more than 1 week. Here, this is a good example how to differentiate different types of viral infections. More or less, they're all similar in presentation, and in that the breathlessness is a significant feature of influenza and COVID. And to differentiate from other viruses, we know the standard COVID, as we know that loss of smell or loss of taste is an important picture of COVID, whereas it is not seen in other viral infections. Next. Here, what are the benefits of using the Oseltamivir? Here, as we know, previously, since long time, we are accustomed to use any sort of pneumonia, go for some antibiotic. Then there used to be a lot of debate about, are we giving antibiotics unnecessarily? Then the consultants used to tell that because we don't have any option, that to pick up the virus, to detect the virus, and to give antiviral also. But those are the days long back. Now, in many centers, we are able to pick up the virus through viral panel. At the same time, even availability of antiviral drug, the presently available is oseltamivir. At one stage, amantadine was the drug which was preferred, but a lot of studies shows that better than amantadine, the oseltamivir is working well, and it is a lot of studies also undergone with the oseltamivir. So this is a prospective study which is done over 3,564 subjects with an age range of 13 years to 97 years, and with influenza-like illness, along with 10 placebo-controlled double-blind trials of oseltamivir, they were analyzed, which showed that significance of the oseltamivir. Next.
Sir, now let me have the discussion about the case discussion, sir. A 4-year-old boy admitted with history of fever for last 6 days, along with the cough and cold since 5 days, sir. So on examination, child is having respiratory rate of 45 per minute, along with the irritability, chest auscultation, bilateral crepitations are seen. Other parameters are very much normal. Weight of the child is 15 kg, sir. In this case, Sri Krishna garu, how do we proceed? What is the initial management? And what are the basic investigations to be done in this case? Really, if you think of viral, do you start antibiotic on the day of admission? If so, which antibiotic?
Yes. Okay, how do we proceed? It's one of the common case what we come across in our hospitals, and how to proceed. Like any case with respiratory distress, this particular child is having fast breathing and sick looking. So any case with respiratory distress, invariably we need to admit in ICU and start oxygen in convenient method as per the age criteria and the severity of the distress. So this child should be started oxygen, and they give supporting care and IV fluids, because most of the time the children with respiratory distress are dehydrated too, and also they are not in a position to take any feeds. So you can give the dextrose supplements, but most important thing is prevent dehydration, and by giving good IV supporting care, and do the basic investigation, because it is suggestive of a lower respiratory tract infection. Do the basic investigations. So what are the basic investigations as it's given in the here? What we want is CBP and chest X-ray, the most important. Why CBP? Basically, in CBP shows the differentiation between bacterial infection and viral infection by the WBC count. As we know, most of the times in viral infection, WBC count is normal or sometimes less also. Whereas chest in X-ray can show if it is a bacterial pneumonia, the infiltrates are more, or they are in the like a lobar, or one total area of the lung, or sometimes even the pleural pathology. Whereas in viral infections, most of the times it has to show the hyperinflation with infiltrates, peri-alar infiltrates will be seen. So regarding the antibiotics, as we know, the IMNCI guidelines very clearly says that any lower respiratory tract infection, straight away start amoxicillin till you get the investigation positive. So here is an X-ray picture. As in this particular case, CVP is a normal. Chest X-ray shows the bilateral interstitial infiltrates present. So here is the bilateral interstitial. You can see in this, the chest overall is hyperinflated. How do we know? Because the presence, if we can count the ribs, and if eighth rib also present in a child, it indicates that the lungs are hyperinflated. As you know, in the viral infections, even the some amount of bronchial obstruction along with hyperinflation is a typical picture. Plus, bilateral interstitial infiltrates are evident in this. In this particular child, it is H3N2 was positive for influenza A. This is what we come across in last 3 months. Quite a good number of cases of H3N2. So now the question comes, does the case require antiviral drug or not? Antibiotic I discussed. The basic antibiotic should be started for all cases of lower respiratory tract infections that needed admission. On other hand, antiviral. If so, which drug? As we know that the multiple viral infections are very, very common, we cannot say whether this particular patient is having the viral infection due to RSV or due to influenza or COVID. But we have a clear drug available for influenza, and delay in starting the oseltamivir can cause complications also. So nothing wrong in starting antiviral drug here. So any child who is having a viral lower respiratory tract infection, if you start oseltamivir, and it can show, because the antiviral drugs, they can shorten the illness if started much earlier. Even if it is late, better late than never. So in these cases, if in the viral panel also may take some time, 1 to 2 days time. So straight away, if there are features of viral LRTA, we recommend directly using the oseltamivir, which is started as 3 mg per kg body weight in oral form twice daily for 5 days.
Sir, so thank you, sir. The influenza A, which is common, and H1N1 and H3N2 are subtypes which are very much common in the our scenario. And you know very well, because of the influenza having more genetic variations frequently, that causes a huge headache for the community, and also for the the treatment part also, because whenever the genetic variation is there, whenever the strain changes, That's why we advise the vaccine has to be taken every once in a year for at least 6 to 7 years for the children, and also in adults to avoid the COPDs and other bronchial cases or other pneumonia cases. We do advise this influenza case has to be taken, vaccine has to be taken. And in these conditions, the emergency warning signs of flu sickness, both in children and adults, will be there, because as a pediatrician, let us focus on the in children. See, being unable to treat, eat, and has trouble breathing, has no tears with crying because of the dehydration, because of the effort, because of the calories, and the child will not be having tears while crying also. So, and normal child will in winter, or normally babies or children will be passing urine frequently. But we have in this case, because of the dehydration, significantly fewer wet diapers can seen than normal. So whenever the case is seen in our OPD or in emergency, fast breathing, bluish skin color, and will not be child will not be able to take intake. That's why we Sri Krishna Garu said that to give IV fluids to maintain the dehydration, to correct the dehydration. So not waking up or not interacting, child will be dull, so irritable, and maybe in some conditions, fever with rash, we have to confuse. There will be a huge confusion between the dengue-like illness with the our H1N1 also. So we have to keep in mind these differential diagnoses whenever the case of fever with rash is seen. And these are the complications. One is common is bronchitis and ear infection because of the ASOM and SOM can be seen, and pneumonias, whereas all the lower tract infections can land into the pneumonia, and worsening of existing diseases like asthma and COPD and ARDS, and ultimately child is not treated properly, and in emergency child was brought late to the hospital or emergencies, definitely the mortality will be there. So treatment of influenza mainly, as I said, bed rest, increased fluid consumption, and cough suppressant if needed, and antibiotics such as paracetamol has to be given. And since influenza, how we differentiate with others is, one is breathlessness, second is most important is headache and myalgia will be more in influenza. So we have to keep in that mind, and we have to give whenever necessary severe myalgia is there. We can advise NSAIDs, and mostly patients with influenza recover in 3 days. And however, some weakness, malaise will be persisting for few weeks, and we have to give supportive measures always. And Sir Sri Krishna Garu, can you tell about the treatment part with antiviral drugs? You already said about amantadine, previously used to use, and now a beautiful, excellent drug which came into the market is Oseltamivir, where is having beautiful actions. Sri Krishna Garu, can you
Okay.
enlighten on this, sir,
Okay.
please?
So, among the various antiviral drugs available, previously amantadine was recommended, but of course, it was not available in India even in those days, and but was available in USA. Then, from last 15-20 years, it is Oseltamivir and Zanamivir. And what is the difference? Here, amantadine and rimantadine, they are like a M2 ion channel blockers. They interfere with the hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. Whereas the neuraminidase, it blocked the viral neuraminidase enzyme activity. This viral neuraminidase enzyme is very critical in releasing virions from the infected host cells. So here the oseltamivir is active against A and B compared to the amantadine, which was active against only A. So the drug oseltamivir is a potent and selective inhibitor of neuraminidase enzyme activity, and it is the active form of this oseltamivir is oseltamivir carboxylate, which is getting converted in the liver once we give oral oseltamivir. And as already we told, that it inhibits the viral replication. That is the most important action for it. So that when the viral replication is arrested, obviously the host immunity can control the viral infection, whereas this person cannot transmit the disease. So even for the community purpose, this the drug which will arrest the viral replication is very, very useful. As I already told, that it's effective against all strains of influenza A and B. Here is a mechanism showed where the generally whenever the viral RNA enter into the host cell, it will replicate, it will alter the DNA structure, and it will replicate, and it will release the virions. And these virions are the one which are spreading, and these new virions cause a continued viral replication. This is viral replication is basically inhibited. Here in the lower part, you can see how this particular receptor containing sialic acid, this is the site of action for oseltamivir, where it can block the release of the viral replication by controlling the virions that halted the viral replication.
So it was nicely dealt by sir, the mechanism of action. And important thing is why we choose oseltamivir is it acts on both on influenza A and B, whereas amantadine or amantadine will be isolated to use for the influenza A only. But B, in most of the cases, 60 to 70% are influenza A, whereas 20 to 30% cases are influenza B also. So oseltamivir is having a wide spectrum of action on both the things. That's the so, and it's the first oral neuraminidase inhibitor, and it's approved more than 100 countries. And coming to the second case, sir, there is a 6 years old girl came with fever and rhinorrhea for 6 days and cough for 3 days. Known case of bronchial asthma on irregular treatment. And on examination, child is having severe bouts of cough but less fever now, and bilateral cryptations with mild wheeze present. So in this case, do we suspect flu infection in this child, or what is the criteria? Because child is a known case of asthma. Child, if you normally if the mother or parent says that my child is having asthma, sir, she used to get frequent episodes, means our mindset will go towards to the bronchial asthma only. But we have to, because we have to rule out other cases, because we have to see the symptoms and clinical signs also. Child is having a fever, body pains, everything. So do we suspect flu infection in child? What is the criteria? As there is a past history, could be the simple post-viral asthma, which may require only bronchodilators but not antivirals. Can you tell about this condition, sir, please?
It's a really interesting case because nowadays the cases of asthma also increasing. And what is the relation? What is the association of asthma with influenza? The children with asthma are more prone for influenza infection. This is the reason generally flu vaccine, if for all children we advise till 5 years only, whereas for the asthmatic children we advise almost for 10 to 15 years, we advise them to get regularly vaccinated. Whereas that means the asthma can get aggravated by influenza virus, whereas the children with asthma are at high risk of getting influenza, that is flu infection. So in general, any virus can trigger asthma. That we know that very commonly, most less than 5 years. First, initially start with a fever and cold and cough for 3 to 4 days. After that, the fever subsides, but the wheezing continues. So it is a viral induced asthma, whereas vice versa also, that the children with asthma are at more risk. Then the problem comes that during asthma, if you give steroids, it will flare up the viral replication. On the other hand, if you just give the viral treatment, then we cannot control the even asthmatic symptoms also. So this dilemma always comes. Hence, all asthmatics require regular flu vaccines along with other preventive measures. Next. So what are the guidelines? So the children require empiric treatment. For this, straight away go for start the oseltamivir, and it should be started as early as possible. And you don't wait for the negative lab test. Many times H1N1 it does not, negative lab test does not exclude the diagnosis in all patients. So start flu vaccine, Oseltamivir as early as possible. And because the viral panel is not available in many centers. So please don't wait for the viral panel also. Straight away you can start Oseltamivir. So especially high risk individuals like this present case of asthma, they deserve more to start early the Oseltamivir. And an early empirical supportive therapy and is very effective, especially even whatever is the virus, nothing wrong in starting the oseltamivir. Just like I say, empiric antibiotic treatment should be based on a clinical diagnosis, whereas empiric therapy with neuraminidase inhibitor for the treatment also with influenza when there is a local circulation or other risk factors. So especially after the travel history or exposure to animal influenza, you can advise it.
Yes, sir.
So,
That's nice, sir. The important thing is we can treat the presumptive management is more important in a severe cases because, as you said, to do the viral panel, two things are important, sir: time and also money. So few people are doesn't have that much money to go for a viral panel, which is costing around 10,000 rupees. So what they prefer, we prefer as a clinicians, is seeing the case. If the child is having really toxic and fever and lower respiratory tract infection, we have to exclude first bacterial or viral. If you feel that viral and with a CBP and chest X-ray, the best thing is to start presumptive management with the Oseltamivir, and it doesn't have any that much worry to have the thinking that having any side effects or not. It's not like that. So this type of anti-influenza treatment such as Oseltamivir prescribed for adults with community-acquired pneumonia also who are test positive for influenza also, sir. And also oseltamivir is associated with reduced risk of deaths. As earlier said, antibiotic use was come down, LRTA complications has come down, hospitalizations has come down. And here the thing is deaths, the mortality has also come down whenever we start the presumptive management with oseltamivir. Treatment within 2 days of symptom onset or hospitalization will result definitely with the best outcomes. So here the case study, sir, the same case having normal picture of CBP and bilateral interstitial infiltrates and hyperinflated lungs, and viral panel was sent, and H3N2 was positive for influenza A, sir. So how do we manage in the same asthma case, sir? Please, sir.
yes. Here, we initially you have to control the viral infection. So better start oseltamivir. This case is got admitted in our center. So we have started oseltamivir. After the first 3 days, the asthmatic symptoms like wheezing were managed with the supporting oxygen and frequent bronchodilation because we didn't start the steroid at that time in view of the influenza infection. So first 3 days oseltamivir was given and continued for 2 more days. Once the fever controlled and we started on her standard asthmatic care and regular inhalers along with steroid inhalers.
Yes, sir. That's great, sir. So why this case was kept? Because we have to. There shouldn't be a confusion between the child known asthma having the viral infection. We have to continue the viral part treatment with the oseltamivir. Child improved, and immediately the post discharge, we advise the treatment should be for the asthma. So prolonged asthma treatment has to be given for the child for the good improvement. Here is the third case. Very interesting. One more case, sir, for the audience. A 2 years old boy admitted with high grade fever for 2 days, along with cough and cold for 2 days, and breathlessness for 2 days. A very short history, sir. On examination, child is very much restless. Respiratory rate is 60 per minute with retractions, and fever is high grade 103 degrees. Notice. And in this case, what will be the initial management, sir? Do you start presumptive anti-flu because the last 10 minutes we are saying presumptive management with salt does it this case needs oseltamivir presumptive treatment, and what is the criteria to start with?
Okay. Here, uh, first question comes: is it a viral infection or bacterial infection? Because we are accustomed to start antibiotics whenever there is a cough, cold, fever, and breathlessness. But the thing, what the important tip for the all the practitioners is, when both cold, that is the upper airway, and the cough with breathlessness, that is lower airway, when both are involved in a period of 2 days, 3 days, 99% it is a viral infection. Whereas the bacterial pneumonias usually don't have upper airway symptoms. So this is a hint in this particular child, 2 days only. So we got because both cold and cough both are there. So it is we have given supporting care as like any other case with oxygen and IV fluids, and even antibiotics also as per the guidelines. Whereas anti-flu should be given or not. Here, as I told that early you start oseltamivir, the faster will be recovery for influenza cases. Then the question comes: are we really dealing with influenza or some other virus? No problem. Whatever is the virus, because if this is a case of influenza, whereas which take time for our to prove it by viral panel. If you start oseltamivir and you can give oseltamivir till the viral panel report comes. So here the indications, what are the guidelines for the presumptive antiviral therapy is all suspected cases of viral LRTA should start oseltamivir. Number two, all confirmed cases. This is, we know that once you confirm, you give it. Third is all the cases with underlying risk factors like a chronic lung disease or asthma, or the children who are already on steroids came with or any other immunocompromised drugs came with the respiratory distress. For all these cases, as early as possible, straight away go for oseltamivir, that is antiviral therapy. Uh, then,
Yes,
this
sir.
is the case with CBP showing lymphocytosis with neutropenia, which is again typical of viral infection, and X-ray also showing the bilateral interstitial infiltrates with hyperinflated lungs. That shows some amount, as I previously I told that many viral infections have some amount of bronchus involvement also. They do have the air trapping. So hyperinflated lungs also one important feature of many viral infections. This particular case got H3N2 positive for influenza A and dosage guidelines. So we have to go for dosage. Here is a very nice chart which shows the dosage and its recommendations. Here the adult dosage is 75 mg capsule twice daily. Whereas for this is for therapy. Whereas for chemoprophylaxis, the dosage is same 75 mg capsule, but it is a once a day for 10 days. I'm just repeating it here that for if you, as a therapy, when you are using oseltamivir, 75 mg capsule twice daily for 5 days. Whereas for chemoprophylaxis, 75 mg OD dose single once daily for 10 days. Now come to the children. The children, the syrup is available, suspension is available with the 12 mg per ml. That is 5 ml contains nearly 60 mg. Then what is the dose? As previously I informed, it is a 3 mg per kg body weight. If you take roughly up to 15 kgs child, he requires 60 mg per day. Divided into two divided doses, that is 2.5 ml. 15 to 23 kgs, it is 90 mg per day, that is a 3.75 ml twice daily. And for a 23 to 40 kgs child, it is 120 mg per day. And so again divided into two daily doses, that is coming to 5 ml twice daily. That is 5 ml contains 60 mg. So 5 ml twice daily is sufficient for a child above 25 kgs till 40 kgs. And above 40 kgs, just like an adult only, you can treat it. So even for the infants, 2 weeks or less than 1 year of age also, the 3 mg per kg body weight straight away you can apply. So please remember all these doses, that each ml contain 12 mg of the oseltamivir, that is a suspension, and the dose is 3 mg per kg body weight. And next is, for as a therapy, you give same 3 mg per kg body weight twice daily. For prevention, you give same 3 mg per kg body weight, but once a day for 10 days.
Yes, sir. It's a great, sir. Easy to remember is 0.25 ml per kg,
Yes.
2 times a day. So if the child is 10 kgs weight, 2.5 ml BD. That's it for 5 days. If the panel comes, if the report shows negative, we can stop immediately, or else we can continue for 5 days. There's a good message for the treatment part, sir. So the same child is having 5 years old sibling with nephrotic syndrome on steroid therapy. Why this case was kept is it's normal. H3N2 positive, influenza A is positive. But this case, as you earlier said, whenever child in a epidemic or endemic or in the same house, the children are 3, 4 children or kids are there having the same infection, but one child is positive for the H3N2 and influenza, but other children are not gone to the doctor but still suffering with the cold and cough and fever. So in these type of cases, the same sibling is having nephrotic syndrome on steroid therapy. What is the risk for him? And do you recommend any preventive therapy for this case? If so, which is
Yes,
the antiviral? Is it
yes.
antiviral drug oseltamivir or influenza vaccine for the nephrotic syndrome sibling? I'm not asking not the case in case person, but sibling is having nephrotic syndrome on
Yes.
steroid therapy. Please, sir.
Okay, a good question. Previously, I told that the who require oseltamivir. The patients with immunocompromised conditions are definitely at high risk of getting flu virus infection. Not only just infection, the severity of the infection is more in immunocompromised patients. That too, when we come to know that one sibling is having influenza, and the other sibling is immunocompromised, like in this particular case, nephrotic syndrome on steroids. As such, nephrotic syndrome, they are immunocompromised because of the low proteins in the circulation. The second is steroids are adding to that. Both constitute the immunocompromised status. Here, can we give vaccine? Yes, in general, when one sibling is suffering with already suffering with influenza, then there is no role of vaccine here, because vaccine will take at least 1 to 2 months time. So you have to go for antiviral drug. So that is a prophylactic antiviral drug, oseltamivir. Then what is the dose? As in the previous child, we told that a 3 mg per kg per day, twice daily, because that was a child with positive viral panel, whereas here we are using prophylactically. So this child require 3 mg per kg per day only, but it is as a single OD dose, and it should be given for 10 days.
Yes, sir. So in OP normally, sir, in OP setting, antiviral treatment has to be given in necessity will come for us. Every case we can't admit, but in spite of that, child is somewhat having fever, influenza-like complications, and suspected or confirmed influenza disease. If treatment can be initiated within 48 hours of onset, definitely the high risk of complications will be avoided. And second thing is antiviral treatment may also be considered for children with suspected or confirmed influenza disease whose siblings are household contact. And we have to give chemoprophylaxis for these cases. Around 10 days has to be given 3 mg per kg per day OD dose. And either are younger than 6 months or high risk conditions that predisposes to the complications of influenza. So this is again the same preventive antiviral therapy. Chemoprophylaxis is advised. Those who are exposed, asymptomatic children and high risk of influenza complications, but not yet immunized, has to be taken the preventive management of oseltamivir. And those who are not expected to mount on effective immune response, if the child is having less resistance and less immunity, those children also maybe immunodeficiency, we have to give the presumptive management with oseltamivir. And this one more case, sir. 12 years girl admitted with fever and joint pains for 4 days along with mild cough and for 2 days, and she is not a known case of chronic lung disease, but child is restless, child with cough and low fever, mild arthritis present, bilateral crepitations are present. Here, the case why is it was interesting is child is having fever with joint pains, and also it's a short history and mild arthritis present. And do we suspect any associated connective tissue? Because you said any conditions like with influenza illness, the comorbid conditions will flare up automatically because of the inflammation.
Yes.
So, in this similar case, do we suspect any associated connective tissue disease with flu cases, or will it alter the disease course in these conditions? In this case, sir, please.
This is really a peculiar case which we got it. Actually, this particular case after influenza positive, it gave the with the generalized body pains and joint pains, and CVP picture was showing normal, whereas chest X-ray is a bilateral interstitial infiltrates, and ANA profile was normal, but viral profile influenza B is positive. Next, here among the various connective tissue diseases, only interstitial lung disease is known to have association with influenza virus. That means the influenza virus, when it is not properly treated, or influenza virus in a chronic lung disease, it can lead to interstitial lung disease. Whereas on the other hand, the virus can trigger any ILD in people with underlying chronic lung disease, whereas a frequent viral infection might play a role in development of progression of the chest condition, connective tissue diseases. All patients with, that's why all patients with connective tissue disease should receive a regular vaccination against influenza. This has been proven well in America, where the cases of influenza, and even the connective tissue disease are also very high. This is one
Yes.
reason. This is one reason why in USA and many other European countries they advise flu vaccine throughout the life every year, because
Oh.
generally these connective tissue diseases they start appearing after 10 years of age. Who will take the risk? So it is they are
Yes.
advising for every child.
One more
So
important, sir. Till now, three cases are we had presented with the influenza A, but here the importance what was given is the diagnosis is viral panel was sent influenza B.
yes,
So this is the where we want to focus on that, because other antiviral drugs will not act on influenza B, but
yeah,
this oseltamivir definitely have a wide spectrum action on both influenza A and B. That's why we kept this slide to differentiate between the clinical picture and medication management between A and B. And A is common, more severe illness in adults, and with constitutional symptoms are severe. And also complications are pneumonia is more when compared to B, because 60 to 70, 60% of the cases will be influenza A, 20 to 30% will be influenza B. And influenza B will be, most of the children will be affected, more severe in child below 5 years, and clinical picture of the children will be the same as influenza A, and medical management is same for both A and B. And only thing is important thing is because mutations are more in A, so that's the reason why genetic variation will be more and infect more persons in the because of the influenza A. So the quadrivalent vaccine include both the strains for the prevention is there, and these are the non-pharmacological and pharmacological preventive measures. One is most important is hand hygiene. You said one is spread to the droplet infection. Second is because of the shake hands and other things. So we have to keep hand hygiene in mind and wash hands frequently with soap and water. And whenever the cough and sneeze etiquette is there, teach the children to cover their mouths and noses so that with the tissue while coughing and sneezing, so that the droplet infection will not spread to the other patients and other children. And the clean surface, when you apply disinfectant frequently, the touched surfaces and objects such as toys, doorknobs, and bathroom taps, especially in the family is becoming more, one of the member is ill, all this will be causing infections. They touch everything. So if we touch the same thing, the other kids or parents or family members touches the same thing, they get infected. So we have to clean surfaces whenever necessary. And pharmacological, the most important is vaccination annually, and also if the child is sick, prophylactically oseltamivir or chemoprophylaxis has to be given for the other members if they are sick. And this is a few questions, sir. We'll fastly wind up. Uh, has the incidence of viral infection increased? What would be the possible reason, sir?
Yes, there are two reasons for the increase in viral infections. One is because most of the time previously bacterial infections were also very high, but we are using antibiotics for many cases. So obviously the number of cases, respiratory cases, what we see now, we can presume that most of them are viral infections. Number two, whenever there is a fluctuations in the weather, or whenever there is a big natural calamity, then the chance of a rise in the viral infections is very clearly known, especially flu virus, which we have seen after tsunami. There is a sudden rise of swine flu. It is across the world also. There is in any area there is a big volcanic explosion, or any too much of heat waves or too much of cold waves, or even any other big natural calamity. After within 1 year of that particular area, there is a rise of viral infections, and especially among them the most common being influenza virus. So there is definitely there is an increase in viral infections.
Yes, sir. So that's a good. Has the incidence of viral infection really increases, sir, day by day? And generally, how soon the child is brought to pediatrician? Here, I want to mention in my experience also, most of the children will not be brought on day one, day two, sir. The mothers, and because we live in metros and cosmos, their parents are much educated. So what they do is they give some paracetamol or NSAIDs everyone, and they get the from the counters, and they get the treatment part. After 2 3 days, once the child has not improved, only child will be brought to the pediatrician. What is
That's
your
true.
experience, sir?
That's true, because many times nowadays the patients, our parents don't have much time to give to the doctor. Many times they try to use the medication at home, and after 3 or 4 days they are coming to the doctors. So if in case of influenza, they are losing the precious time of starting the oseltamivir. That is a sad point of it.
Yes, thank you, sir. Thank you. Should Oseltamivir started? Yes. In our
Yes.
lecture also we said Oseltamivir to be started empirically and or after investigations, means before getting the viral panel. Better to start empirically the Oseltamivir, which has that there is a study of 3,000 sample study where hospitalization has decreased, lower respiratory complication has decreased, and also
Mm.
antibiotic use was decreased because of the presumptive use of Oseltamivir. So these are the studies. And can I, sir, what are the factors on which clinical response to oseltamivir depends, sir? Please.
One is early suspicion and early initiation. This is the most important thing, that you suspect. Already we discussed how early we can detect by looking at the viral LRTI picture, and start early. That is the most important thing, where the most general public will be benefited by starting this. On other hand, immune status of the child also, like those who are suffering with the immunodeficiency states, like malnutrition or any chronic infections or any steroid therapy or already anti-malignancy therapy or drugs. So all these are, and even the chronic lung disease and heart disease are at high risk of getting the infection. So if we, they may have, after, even after starting oseltamivir, their response may be little bit delayed. But nevertheless, it is better to start oseltamivir for all these patients of these immunocompromised conditions.
Sir, the message is you get a beautiful clinical response if you start oseltamivir early, and if you suspect a case, you have to initiate the treatment. And in all the immunocompromised conditions also, maybe response is delayed, but you will get a good clinical response if you use the oseltamivir presumptively. And yes, we said about how long should oseltamivir administered. Should be given for 5 days, and as a chemoprophylaxis, it has to be given for 10 days OD dose. And the next is, Sir Sri Krishna garu, do you prescribe antibiotics concurrently, sir?
Uh, for airway, general guidelines says that wait for antibiotic for 3 days whenever any patient with cold and fever comes. But for the lower airway condition like breathlessness, don't hesitate to start. Then which antibiotic? It is as per a IMNCA guideline. Still, amoxicillin holds good, so you can start antibiotics.
Sir, you are a private practice. You are a government. You are belongs to Apollo as a professor and HOD, sir. As a common practitioner, if he doesn't start, most of the parents will ask, "Oh, sir, are you writing antibiotic or not?" We'll counsel them. Its antibiotic is not needed. Child will not have response for 3 4 days. He goes to the other doctor. Will the practitioner will lose the practice. How to do this counseling part? How to make the trust in the counseling? Can you advise, sir? Because
Yeah.
normally we lose. If I see don't write antibiotic on third day or second day, the patient will go to other doctor. He will start some antibiotic, and child will improve, and he will have confidence on him.
One
So how
thing,
to?
Dr. Sridhar, very nice question, is always a hot debate topic. The issue is when you know that this is a typical viral infection with the already I told that upper airway and lower airway involved, and second is the CBP, of course, if you do it, or even the present season going on, there is no point in even if you give antibiotic, it will take 3 days to 4 days time minimum response. So when it is already taking that, it is better you only tell them, because generally I do that this is looking like a viral infection which is going to be there for 5 days. Please bear it, but if there is no any complication, get them back after 3 days.
Okay.
So if there is an improvement, they don't themselves they are confident about the doctor and they don't come, but they don't go to other doctor. Whereas if when we ourselves tell that if there is not much improvement in 3 days, we'll start some other medication. Obviously, the patient tendency also there to avoid one more consultation money. So definitely they will come to us.
Okay, thank you. And how is oseltamivir tolerated? Having any major adverse effects? Yes, but rare but serious skin conditions are seen in some few cases, like blistering, peeling, and loosening of skin. But in our experience of these 7 to 8
We
years
have
or
not
9 years,
seen. Yes,
we have
I
not
have
seen,
not
sir.
seen.
And any contraindications, sir, precautions to use oseltamivir, sir?
As such, there is no contraindication in children. The report says, the textbook says that certain drugs like probenecid and dichlorphenamide should not be given, but generally they are adult drugs, not for the children.
Okay, sir. So this is the summary, sir. Proper diagnosis can early treatment can prevent flu complications, and empiric use of oseltamivir reduces lower respiratory tract complications, hospitalizations, and antibiotic use. And WHO and American Thoracic Society and Ministry of Health and Family Welfare recommends empiric use of oseltamivir. So once again, I want to thank my co-panelist Dr. Sri Krishna Surampudi sir is the Apollo HOD. First of all, we have to thank Etro and myself has to thank Sri Krishna Garu. These are all the 4 cases belongs to our Apollo hospital. With his kind gesture, he had given me opportunity to present these cases. Thank you, Surampur Sri Krishna Garu, and thanks Etro
Thank you,
for
Sridhar, for
bringing this.
asking nice questions. And special thanks to Hetero for two reasons. One is previously, long back, even though we suspected and we diagnosed, we were not giving any antiviral drugs. And making it available in India for one of the most common respiratory viral infections is really, it makes difference. And we had a very good experience in the month of August and September. We had a big series of cases in our hospital where many cases have received oseltamivir. And of course, if when you see the cost, also it is very, very reasonable cost and they got very good benefit. So before we used to send the viral panel and immediately start oseltamivir. Almost 70% of the cases got positive. And by the time the viral panel report comes, they have improved also. That shows that the prolongation of the critical period also will come down if you start early. So this is what the message I want to give.
Thank
Thank
you,
you
Thank
sir.
you,
so much.
Hetero, for making it convenient.
Thank you so much. Thanks so much, Dr. Sri Krishna. Thank you so much, Dr. Sridhar. Thanks for kind words. Thanks all the doctors who took time from their busy schedule and attended this webinar. I'm sure it was definitely a lot of insights we got. Thanks IT team, thanks marketing and sales team of Hetero for this support. Thank you, sir. You can log off and wish you a very
Yeah,
pleasant afternoon. Thank
yeah,
you.
yeah. Thank
Thank
you.
you.
Special thanks to Mirza. Convey my
Yes.
thanks.
Thank
Certainly.
you.
Thank you.
Okay, okay.